I'm Sharon Eloranta. I'm the medical director here at the Washington Health Alliance. And I want to welcome you all in and thank you for attending our program today, which is titled Home Blood Pressure Monitoring with Clinical Support, Active Patient Engagement for Better Health. We're excited at the Washington Health Alliance to be actively partnering with the Washington State Department of Health to offer you this program today. So in the next hour or so, a little bit less probably, we will hear about a background on what hypertension is, its physiology, and its associated comorbidities and sequelae. We will also discuss approaches to effectively managing hypertension to reduce its related adverse outcomes, and we'll describe the effectiveness of home blood pressure monitoring with clinical support as an important adjunct in helping to reach blood pressure goals for patients, and always with a focus on equity, because we know that hypertension, like many other conditions, has differing impacts on different populations. Following that, we'll do a quick review of the results of a purchaser survey regarding awareness of hypertension and benefit coverage for home blood pressure monitoring with clinical support. We'll come up with some recommendations for purchasers, health plans, providers, and allies in order to take action on this. And then we'll hear from the Washington Department of Health about their current priorities in this area. So a couple housekeeping issues. First, the session is being recorded, so all non-panelist participants are, your cameras and mics are muted. However, we really do want to have your questions and comments, and we will address them most likely at the end, but please send them in using the chat function rather than Q&A. And we really do want your input. We'll address your questions as we get them. So without further comment, I would like to get us started. So I would like to introduce Dr. DC Dugdale, who is a family medicine physician and the medical director for value-based care with UW-Medicine. Dr. Dugdale, the floor is yours.
Great, thank you, Sharon. Can you confirm that you can hear me?
I can indeed hear you, yes.
I'm sorry, a friendly amendment. I'm actually a primary care internal medicine doctor, trained at UW and currently practicing at UW. I'll apologize in advance for any background noise. That should be brief, I hope, and not too much. My presentation is in two parts. One is to define the problem, hypertension. I'll talk a little bit about the demographics and definitions and such, and then talk some about the management. So go ahead to the next slide, please, Sharon. So historically, hypertension has been defined based on blood pressures measured in a medical office setting. In the past few decades, there's been a recognition of the value of taking blood pressure out of offices. And so you'll hear those two different terms. The systolic blood pressure is the higher number. It's the highest blood pressure that happens during the course of the heartbeat. Diastolic is the lowest number. And then in the bullets, you can see the definitions of various stages of hypertension. There is a precursor condition that is elevated blood pressure, typically managed only with lifestyle changes as opposed to medications. And then hypertensive crisis, fortunately, is really a very uncommon condition these days, though that wasn't always true historically. Next slide, please. So hypertension in 2021 was a primary contributing cause of nearly 700,000 deaths in the US. It is the dominant modifiable risk factor for a number of different conditions, all of which are common and linked to morbidity and mortality. It accelerates the progression of common complications in diabetes. So in diabetes, which is also a very common condition, there's a negatively synergistic effect of high blood pressure. And then deaths attributed to hypertension have increased in the past decade. Next slide, please. Sorry. So it's a common misconception that cholesterol treatment is somehow more important than hypertension treatment. That's actually not true. I'm not dissing cholesterol treatment, but the fact is, with respect to impact on mortality, the hypertension has a greater impact, and in terms of better control of hypertension, as the slide says, there's additional deaths that would be prevented in the U.S. So next slide, please. A couple kind of big picture demographics. So nearly half of adults in the U.S. have hypertension using the 130/80 threshold, or based on taking medications for hypertension. You should know that there is some controversy among medical clinicians around whether 130/80 is the proper cut point. That is the cut point advocated by the large national bodies that look at this: American College of Cardiology, American Heart Association. But you'll often run across references to 140/90. That was an earlier definitional point, and it remains a part of many of the quality measure definitions because of the nuanced way in which targets for blood pressure are set for certain low risk adults. But if you use the 130/80 number, then only about 1 in 4 adults in the US who have hypertension have their condition under control. And particularly worrisome are the folks that have a blood pressure of 140/90 or higher. The higher the blood pressure, the more rapid the secondary effects of blood pressure occur. So those are a particularly impactful group. And then with respect to the cost, of course, there's many assumptions that go into these kinds of estimates, but it's big. 131 billion each year averaged over the time period shown on the slide. Next slide, please. There are differences by demographic, by socioeconomic, by racial and ethnic categories in hypertension prevalence and in control rates of hypertension. So it's a little more common in men, more common in non-Hispanic Blacks. That is the most common large ethnic and racial group. And then the last bullet talks about the control rates in the different populations. And again, non-Hispanic Blacks have a worse control rate than non-Hispanic whites. There are many ways to cut these data, but I'm not going to get into more detail than that. Next slide, please. This map shows actually that in Washington State, we are not as bad off as other parts of the country. I will say that the Washington State prevalence numbers, and there's a more detailed slide coming up, is closer to the top of that range, 32.5, than it is to the bottom. But I think the picture shows that there are parts of the U.S. that have honestly a bigger problem with this than in Washington State. However, Washington State, and go to the next slide, please. In Washington State, in 2021, roughly 30% had a diagnosis of high blood pressure, and at least a third, or about a third, did not have it under control. 2/3 had it under control, and there are differences by socioeconomic, racial, and ethnic subclasses there. Age is a risk factor for high blood pressure, and then I already talked about gender. Next slide, please. So just to put a little bit more numerical info behind some of the statements. So American Indian, and this is in Washington State now, it's Washington State specific data. American Indian or Alaska Native adults, about 30% more likely to have hypertension compared to non-Hispanic whites. Non-Hispanic Blacks, about 40% more likely. Adults that live with a disability, more likely to have hypertension. And then those who are on the lower end of the educational scale are more likely to have hypertension, as well as those who are on the lower end of the income scale. This is a pattern certainly not unusual in other chronic illnesses, and unfortunately, it is simply complicates our ability to do the best we can for the entire population of Washington State. Next slide, please. And then this is the more detailed side. You can see that the variations in blood pressure prevalence across the state, and these probably have multiple factors to them, but certainly the geographic distribution of racial and ethnic subclasses for sure is underlying some of this. Even within King County, there are considerable variations in rates of hypertension. And that doesn't show up in the graphic because it's not aimed at doing that. It's only showing county level data. But the second bullet, you can see the range from 15% to 35% within King County itself. So again, multiple variations in the demographics related to hypertension. Next slide, please. Now I'm going to talk a little bit more about measurement because that is a big part of what we're going to talk about today in terms of self-measurement, and in addition is fundamental to both diagnosing and treating high blood pressure. So the principal ways of measuring blood pressure, there's three major ones. The first, and my guess is that almost everybody on the call has had this done at least once, is in a medical office, typically using an automated blood pressure machine. Older versions of blood pressure machines are manual, where the clinician uses a stethoscope to listen. And although that may still exist in some settings, most settings, medical office settings, have moved to automated devices for a whole host of reasons, including greater reliability, easier training, and frankly, just greater availability of the technology. Blood pressure can be measured out of office, and I'm going to equate home with out of office. Recognize that there are pharmacies, for example, that often have blood pressure kiosks. The days in which a person could walk into a fire station and get their blood pressure measured, I think that's mostly gone. Certainly in the area where I live and work, that's not really a service offered by the fire department anymore. But there's a host of blood pressure, validated automated blood pressure machines available for home use. And the website that's in the slide, validatebp.org, is the most reliable listing in the US of that technology. There's a lesser used thing called ambulatory blood pressure monitoring, lesser used at least in the United States. And that in that technology, a person wears a blood pressure cuff typically for 24 hours, and their blood pressure is measured periodically during the course of that 24 hours. A common protocol is to measure every 15 minutes, but that's a variable that can be set in the machine. So that allows measuring it at various times of the day. Person has to wear it, of course. That technology is considerably more expensive and complicated to set up than the home. There are times when it is the preferred method of measuring blood pressure, but that is not going to be true for I would say, the great majority of people that have hypertension, at least in Washington State. It's important to recognize that measurement technique matters. What's on the slide are probably the 5 most important points in this. More than anything, the resting of the arm and placing it, the cuff properly at the right spot. There's plenty of places to get written detailed instructions about this, but that is part of using home or out of office technology, which is to be sure that it's the person doing it, which is typically going to be the person whose blood pressure is being measured, knows how to do it. You don't take caffeine or tobacco for at least 30 minutes. We know that roughly half of people regularly monitor their blood pressure. And then probably the most common protocol, and this comes out of the American College of Cardiology guideline, 2 or more readings taken at any one time. You average those readings and get a single reading for that time. You then repeat that process. And the ACC would say before breakfast and before dinner for 3 to 5 days. That creates somewhere between 6 and 10 readings. That each reading themselves is an average of individual readings, and that becomes the basis for treatment. So it's not a trivial matter to record this. It does take some effort. You can get by with less, but the recommended protocol is what I've described. Next slide, please. So there are a variety of guidelines available for clinicians and for clinical systems around the screening, diagnosis, or management of high blood pressure. The U.S. Preventive Services Task Force, which typically is around screening, gives that a grade A recommendation. It recommends that screening be done with office blood pressure measurement, but that blood pressure that is high in the office be confirmed with an out-of-office method, either the home blood pressure monitoring that I mentioned or the 24-hour that I mentioned before starting treatment. There's a few more nuances to that, but the main point is that it's a grade A recommendation for screening. And then there's a process of confirming the diagnosis that happens after that. The American College of Cardiology and Heart Association, which have been essentially blessed by the NIH to be the representative guideline set for the nation, has a very extensive guideline that's available for clinicians. There's several executive summaries of it because it's so long, but goes into much more detail around the threshold blood pressure for making a diagnosis of hypertension, the actual protocol, and then the treatment protocol. And bottom line is that it advocates using a combination of out-of-office and in-office readings. And in general, the literature supports giving more weight to the out-of-office readings. Next slide, please. And then I think this is the last slide of the first section. So costs associated with care for hypertension, an actually quite important cost is an incorrect diagnosis. And so that is often a result of relying only on medical office readings. And so use of out-of-office readings to confirm a diagnosis is something that reduces the risk of over-treatment of patients and reduces the cost of care for people who aren't going to benefit from that care. So that's would be what we would call low-value care. So that's a really critical piece in terms of understanding the costs. There's other much more easily understood costs, which are the costs of the healthcare for managing hypertension, the cost of complications, disability, etc. But I wanted to emphasize the point that confirming the diagnosis is an important step, because it's fairly easy if you don't do that to end up treating people who don't need treatment in the first place, and that's not a good value in our healthcare economy. Next slide, please. Okay, so that's the end of the discussion, my discussion around the definitions, measurement process, and some of the demographics. The second part of my talk is related to management. It could be a whole talk in and of itself, so I'm going to be fairly high level, but and then at the end we can address questions too. So anyway, why don't you go to yeah, great. So why might hypertension be poorly managed? Well, typically it actually has no symptoms until complications develop. There are exceptions to that, but that's the typical thing. Clinical protocols, although well developed, and I mentioned the American College of Cardiology, there's many others available too, are often not well disseminated or implemented. And that is really a major barrier to doing this as well as we could. Integral to successful treatment is a monitoring and follow-up plan. So keeping both clinician and patient, or clinical team and patient, on the same page, so that everyone's trying to accomplish the same monitoring of blood pressure and the same goals of treatment is critical to success. Clinical systems often lack enough capacity to execute the optimal plan. There's the fundamental of office visit capacity, and that can make it quite difficult to get follow-up at the time that people want if you're relying solely on office visits. And then there's what I've called population management capacity. That's knowing who the target population is. In our own health system, and I'll talk about this more in a little bit, we have a registry of patients with hypertension. So we know who it is that we want to engage and keep engaged in treatment. But just knowing who they are doesn't mean that we have capacity to do that as well as we would like. And this is an area that is well known as a shortcoming for many health systems. And then the final thing I'll say is the innovations, for example, the home blood pressure monitoring, have had a slow and limited adoption. I will say, as a clinician, having had probably literally hundreds of conversations with patients, maybe even more over the years around home monitoring, there are some patients who simply won't do it. And that they either don't want to, or for whatever reason, they will not engage in that. You make the best of that situation, but there's no doubt that the expert literature and a variety of studies demonstrate that if a patient is willing and able to participate in home blood pressure monitoring, it is the preferred method of doing this. Next slide, please. So first, the person has to obtain a machine. We talked about how getting the information about what a validated machine is. I talked a little bit about community measurement sites such as pharmacies and fire stations, and they're a valid alternative, but typically more cumbersome or often not available. The diagnosis is more accurate. I mentioned that already, and saves on low value healthcare by not treating people who don't have hypertension. That really is an important benefit of home blood pressure monitoring, which in a sense predates the actual diagnosis of hypertension. It's in the domain of validating, confirming a suspected diagnosis of hypertension. And then using home blood pressure technology can avoid under or over treatment and reduce consequences of hypertension. Next slide, please. So a little bit about managing hypertension. Historically in the US, we've relied solely on medical office-based blood pressure measurements and what's called a stepped care approach that includes lifestyle modification and medications. There are some health systems, Kaiser is probably the leading health system in this area with respect to hypertension control, with the Veterans Administration being close behind, have had great success with this approach. So they've gone well beyond the basics of what I described in this first bullet. But honestly, most health systems have not had anywhere close to the success of these two health systems in terms of blood pressure control. Next slide, please. And so, as I've already kind of referenced, there's a rising recognition of the value of home blood pressure monitoring. And then intrinsic to some of the guidelines that I've referenced is what I would call a modified step care approach that is more aggressive with medications and particularly more assertive about taking action when blood pressure is not well controlled, rather than continuing to monitor. There's this term in clinical care called therapeutic inertia, in which there's the criteria are met for changing what you're doing, and yet the change doesn't happen. This is a well-known phenomenon. I can't think of a clinician who's hasn't suffered from that at some point. But in a condition that is largely not symptomatic, it's particularly problematic and a major barrier to getting good control of blood pressure. So part of what I do when I train clinicians is to try to counteract that tendency toward clinical inertia. Hypertension is not the only condition in which this phenomenon has been reported and quite well demonstrated, but it is an important one. So that I don't mean over medicating people. That's not what I'm talking about. But recognizing when somebody is not doing well in their current regimen, to make the change rather than to continue to monitor. The first bullet here talks about some of the other organizations that have guidelines around this. There's both other US organizations, and then there's Canada, the UK, many different references available to get information about the clinical side of this. And as I've said once already, the economic value from a payer perspective for home blood pressure monitoring is at least partly related to accurate diagnosis, meaning not treating people without the diagnosis, and to better treatment choice and titration. The chronic management, once somebody is stabilized, it is probably a lower, probably not the place where the saving can be gotten on the home blood pressure monitoring. But in the initial phase and the titration till people are controlled, data really suggests quite strongly that the home blood pressure monitoring is a saving, a cost savings intervention. Next slide, please. There's some important nuts and bolts that can make or break this. Patient has to obtain a machine, have to be trained. Talked about that. On the clinician or clinical team side, there has to be somebody with whom the patient can share the readings and then take action as needed. What that looks like will vary a lot from different within different health systems. Most often it's going to be a primary care medical home type construct, and that's certainly true in my own institution, UW Medicine. But very important things to nail down so that patients know what to do with the information that they're getting. Next slide, please. What we've done within UW Medicine, we have our electronic medical record, which is called EPIC, has a function called Care Companion. Care Companion allows, it's a module that's designed to help patients stay on a desired treatment trajectory. And so the specifics involve the patient being invited by the clinician to participate through a specific patient portal, but then that allows for data to be sent by the patient to the clinical team. As I said, usually it's a primary care medical home, but it could be others. There are many variations on this type of general model, and the capabilities both of the electronic medical record and of the clinical teams, those have to be considered in terms of constructing what will be successful over the long run. Next slide, please. So Medicare has coverage for home blood pressure monitoring, and about 20% of people with hypertension have Medicare coverage. So that's a significant piece of our population. It provides support for both remote physiologic monitoring and self-monitoring of blood pressure. There's a rubric for doing it. Most clinicians would probably say that the money isn't enough. I actually would agree with that. So I think, although it's great that there is reimbursement, it doesn't take much time for the time that's used to exceed the value that's paid by Medicare. However, it's much better than it used to be because previously there was no coverage. Next slide, please. So in terms of effectiveness of management, there's many different studies have been done to demonstrate that control of blood pressure makes a difference. So it's not just a risk factor for cardiovascular disease, but control of blood pressure makes a difference. And in this particular, this is a kind of a synthetic study of multiple different studies. What they looked at was the rate of major cardiovascular events in relationship to systolic blood pressure control, and even getting down below 140, so into the 130 to 139 range, led to an important drop in the rate of cardiovascular events. Go on to the next slide, please. And then a couple of Washington state specific things. We've talked about some of this already. It's fairly common in Washington state to have healthcare professionals recommend self-monitoring. That's good news. And as I said, about half of people report regular checking. I think I'll skip on to the next slide because we've already talked about the age contribution. And I think we've covered this adequately too. So go to the next slide, please, Sharon. Oh, that was the last slide. Okay, so I think my summary would be that the self-monitoring of blood pressure is a proven technology. It's available, not as well implemented as we would like, and any steps that payers, purchasers, employers can take to catalyze its uptake would be a step in the right direction. So I'll go ahead and stop. I'll go on mute, Sarah, and then glad to answer questions.
That's great. Thank you so much, Dr. Dugdale. I particularly found that really interesting in terms of your focus on diagnostic accuracy, because that's frankly not something I've been thinking about, even though I've been putting this presentation together. And I'm glad you clarified that, because overdiagnosis is definitely a problem and something that we need to think about, and the role of these blood pressure monitors in helping to reduce that. So about a year ago, the Washington Health Alliance, at the direction and with the assistance of the Washington State Department of Health, conducted a survey of some of the employers in our membership about the awareness of hypertension and the coverages that they offer to their employees and the dependents. So this is the list of folks that responded to the survey, and about a little under 500,000 covered lives. So it's a decent sample size for this survey. So we started right off saying, wonder how aware folks are of the percentage of folks that they cover that have hypertension, and half of them said they didn't know, so they weren't tracking that. And I think that's an important point. We've got to figure out what the extent of the problem is before you know what you need to do about it. Then we also asked, how high a priority would hypertension be? And as Dr. Dugdale just told us, about half of the people in the United States at least have hypertension. And our respondents were split, equally divided between not a priority and just somewhat, and then the higher answers. So not only did these respondents, we're not saying they're bad in any way, just the information that they shared is that they don't really know how prevalent it is and isn't currently thought of as a priority. And I have to say, coming out of a pandemic, maybe they were working on other things, but there's room for some intervention there. And again, had they provided any education on blood pressure to their employees or dependents in the last 2 years? And 3/4 said they had not provided anything within newsletters or other communications. So again, more of an opportunity. So those are kind of the background questions. And then we started to ask questions about the extent to which home blood pressure monitoring devices, and we're talking about those home blood pressure, not the continuous one for 24 hours, but what we found out about coverage was that about 1/3 of survey respondents would make a monitor available to anybody, regardless of whether they have high blood pressure or not. So I guess there's another space to look for value in our system. But 2/3 of them required a diagnosis of medical necessity for a beneficiary to be able to access a monitor. Cardiovascular disease, a diagnosis, or an in-office blood pressure reading of 130/80 or higher. Within plan types, of which there are many, small group, large group, etc., the benefit seems to be covered throughout those plan types, but it is most frequently present in the PPOs and HMOs, so those kind of more organized systems. And of those respondents that knew, about half did not require pre-authorization to access the benefit, and that's good. It's good that they're knocking down some of the barriers, but that's only about half. And 3/4 of the respondents made the monitors available through a prescription, so as DME or at a pharmacy. So that's another little bit of an extra step, but it may show some need to have that provider engaged in the accessing of the equipment. About 2/3 offered the benefit with no co-payment. Yes, that is great, but there was some co-insurance present, with the average being about 20%. So there are some barriers that have been constructed here to accessing these machines. About 90% let you buy whatever fancy blood pressure monitor you want. There's no maximum amount for the cost of a blood pressure monitor, but there is potentially some cost sharing for the others. Happy to know that respondents provide the benefit pre-deductible of those that do offer it, but the majority did not know or don't cover reimbursement for training the patients to use the monitors. And most were also unaware of the fact that they could, that providers can actually bill for the activity of receiving the information back and helping manage the patients in that way. So those are the benefits pieces. And then going back to the fact that they were not really regularly communicating to their employees and covered populations, there were educational opportunities. So again, half didn't know the prevalence of this condition. 3/4 said they hadn't provided any education in a couple years. And again, most respondents didn't know about the reimbursement. So there's an opportunity for education internally, reimbursement for training the patients, or reimbursement for reviewing the data to collaborate with the patients on management. They were divided between whether hypertension is a priority. And so we need to amplify those messages, because we know if half of Americans have it and we're spending billions of dollars on the condition and the sequelae of the condition, we need to have a little more awareness. And they agreed that hypertension should probably be more highly prioritized in their patient education. So what were implications for our various stakeholders of this survey? Well, last year we created an action brief, which we're going to review and maybe make a couple of updates to, and then will be widely disseminated and available on our website and through many other portals. I was happy to hear that when Dr. Dugdale read the action brief, he said it was excellent. So I'm excited that that was good. But we kind of broke out what our various stakeholders could do. So employers, again, can understand the impact of hypertension. They can provide education for their populations about recognize and manage high blood pressure. They can provide support for their employees who might be at risk for adverse cardiac events. They need to find out and understand the level to which their insurance plan or plans that they offer cover home blood pressure monitoring devices. Both the monitors, and yes, we will be sharing the slides so you can see the codes for obtaining the monitors, training for the team and patient education, and try and reduce the barriers to this with no cost share if they can. So employers can work with their health plans to see if they can reduce some of those barriers. Insurance plans could include pre-deductible at-home blood pressure monitors as a benefit to their employers in our state. Reduce all of these financial hurdles. I know we're being aspirational here, but it would be great if we could limit co-insurance rates to no more than 20% and eliminating copays. Insurance plans can educate their healthcare professionals that are within their network about the fact that there are payment codes to cover the monitoring devices for and blood pressure cuffs, and then within their health plan structures, reimburse the providers who do the trainings. You can see the codes there, and compensate providers for the actual receiving and reviewing of the blood pressure data to help keep them informed of patients' progress. And I think over time, if more people are accurately diagnosed with hypertension, whether they have it or not, and then if they have it, if they're well managed, there should be savings that would accrue then to those insurance plans. And providers, of course, can recommend and train patients on the use of these devices as a key point in both diagnosis and management. Develop their systems. I think as DC just talked about with regard to the UW system, they have a system where they're able to collect some of that information from their patients and use this data to collaborate with patients on management strategies, whether that be the combined sort of lifestyle plus medication management. And then develop a clear blood pressure management clinical pathway. Again, you have an example from UW Medicine about how they work with it. to facilitate more rapid medication titration, if that's what's indicated, and task delegation among the clinical team. And by task delegation, I refer back to what Dr. Dugdale also talked about when he talked about the person-centered medical home and having the responsibilities for working with this, not rely 100% upon the physician or physician assistant or advanced practice registered nurse who is the leader of the team, but other members of the team can collaborate on this to help provide these valuable benefits to the patients. So kind of in summary of our action brief, we quoted U.S. Department of Health and Human Services Secretary Alex Azar, who said that high blood pressure is a threat to our nation's health and the time to act is now. So we know that employers and plans have this opportunity to really reduce the prevalence and devastating effects of unmanaged high blood pressure on employees or families in our system. And we really recommend reducing barriers to accessing the monitors with clinical and increasing clinical support. This kind of repeats itself again, but again, why should we do this? We're going to decrease time of exposure to damaging blood pressure levels, hopefully leading to a reduction in morbidity and mortality secondary to or including high blood pressure. We want to improve health equity across populations. And, as Dr. Dugdale mentioned, high blood pressure and the adverse effects associated with it impact non-white populations more than they impact white populations, and populations that live in with more socioeconomic stress in their daily lives tend to be more highly impacted, reduce absenteeism, reduce healthcare costs, and improve bottom lines. So now I would like to invite Sarah Eve Sarlicker, who is a cardiovascular consultant for the Heart Disease, Stroke, and Diabetes Prevention Unit within Prevention and Community Health at the Washington State Department of Health, to tell us a little bit about current priorities for the Washington State Department of Health.
Thank you so much. Excuse me. Thank you so much, Dr. Eloranta and Dr. Dugdale. I'd also like to thank the Washington State Cardiovascular Disease and Diabetes Network Leadership Team that really contributed to the development of recommendations and of the survey that we conducted. So our current recommendations are to provide validated blood pressure monitors without prior authorization copay, as Dr. Eloranta mentioned. We really want to see that care teams get reimbursement, or it's included in value-based design for them to get the accurate measurement and reviewing of results with patients, really promoting the awareness of high blood pressure and the benefits of self-monitoring through all available channels. And really in terms of the types of providers that can provide this care and see reimbursement, we really want to see pharmacists and pharmacy teams included in this. We have some examples of that happening in our state, and that's really exciting. So next slide, please. Okay. So what we're doing at Department of Health, we have patient-friendly materials that are available in multiple languages that are free and can be ordered from us. And we provide trainings for community health workers in supporting the accurate measurement of blood pressure so that when someone leaves the office, they have some support as well. We are expanding access to the Healthy Heart Ambassador blood pressure self-monitoring program that was developed by the Y of USA and in partnership with CDC is now being spread to non-Y sites and is available in both Spanish and English. And we have trainings coming up before the end of the month as well. We are aligning with Care Connect Washington, which is the system that was developed during the pandemic emergency to support vulnerable people who had or were exposed to or impacted by COVID. And that is transitioning to a system that can support people with chronic health conditions. And this is happening across Washington State. And we are aligning to support that work and really encourage the self-monitoring piece and support through that. We also coordinate with organizations to measure and track the social factors that influence health among people with high blood pressure. And so as more health systems are including the sort of social determinants of health screenings, we're wanting to see what does that look like when we look at the population with high blood pressure? And are there specific levers there that we could have an impact on? And then we also provide at the statewide level staffing to focus on cardiovascular disease and coordinate statewide and regional efforts. So thanks. Next slide. So what can you do? So for employers, we encourage plans to cover the devices without barriers, to provide regular education on hypertension management and understand the prevalence, just what's going on in your population, your employees and your enrollees. For health plans, provide monitors without prior authorization or other barriers. And providers are doing this more and more, where they are encouraging patients to do home monitoring. Just met the provider yesterday who said that this is something that she does with her patients. And if it's necessary to provide a prescription, depending on the insurance coverage, and to do so. And then have the team look at your team and see who can train patients on monitor use. It's not expected that that licensed provider is necessarily the one that does this. They can be, but if you have other team members who can do this, that is fantastic. It does not require a licensed clinician to train someone on getting an accurate blood pressure reading. So allies, Accountable Communities Health, community-based organizations, support patients in obtaining and using home monitors. If you're interested in offering a program of support, you can reach out to us and we can connect you up with those resources. And I also just want to say, when we think about equity and we think about what impact this could have on equity, so there is people who are themselves low income, but even people who have higher incomes, if they are have family members either here or abroad who need additional financial assistance. So we think about like that generational wealth or wealth that's within families. So if you have someone who's a higher income earner, that income isn't necessarily staying in their own pockets or in their own families. It may be spread throughout their extended family, throughout their community. So even if someone is earning at the higher end of that level, depending on what is going on for them, they may not truly have the resource to do this. And then just having it covered, having it available, really does reduce barriers. And that does seem to be the biggest barrier that is being encountered, is really people purchasing the device themselves if they are interested in doing this. So that's where we are. So thank you. I think that's the last slide. Yeah. And any questions? I'd love to hear any discussion. I do have a question for Dr. Dugdale, so I can wait though.
We do have one question that has come in over the chat, and I think either of you, if you know, do the codes, oops, what did I just do wrong? Do the codes cover nurse care managers reviewing the hypertension readings, giving directions on how to use it, or does it require a PCP or the managing provider to enter those codes or provide that service?
This DC Center, I can speak to that. So in the slide that I showed that listed the two codes, the first code was for initial education. That can be submitted by independent practitioners, and it's typically understood as that it would be somebody else who works in the office besides the clinical provider. That's done just once per device, so it's not an ongoing thing. The other code, which essentially is the review of readings that happen, and then taking action on those. There's a fair amount of fine print in exactly what you have to do in order to build that, but it is recognized that some of the work, frankly, a lot of the work in that is also can be done by members of the clinical team rather than the independent practitioner. I'm going to read just a couple of the requirements just so people understand this. So that 99474 code, it's reported over a 30-day period. there has to be a minimum of 12 readings, and there's some additional specificity about that. And then the data can be reported by a patient or caregiver, and then the languages to the physician or other qualified healthcare professional. And then there's a report of the average blood pressure and subsequent communication of a treatment plan to the patient. So, I mean, that's not so complicated in terms of that it's different from what we might normally do, but it lays it out in black and white. And so you can imagine that a significant part of that labor could be done by a non-independent clinician. On the other hand, maybe it isn't. That depends on the system. But so that'd be my answer. There are some other important caveats that because there's other types of remote monitoring codes that are also used. You can't report both. You have to report one or the other. That 99474 is very specific for blood pressure, whereas remote physiologic monitoring is a broader group of types of data.
Sorry, did you say you had a question?
I did. So Dr. Dugdale, when in terms of that morning or evening reading, do you recommend that patients check their blood pressure before they've taken their blood pressure medication, or does it depend on the type of medication they're taking?
So the guideline is silent on that question. I mean, my answer would be take it before. That's what I would do if I were doing it. And I actually have done this myself to both see what it's like to do and to report back to my clinician. So that's how I've done it. I think there might be times where you might do it after the medication. If you, for example, thought that somebody was getting a low blood pressure in the relatively short time after taking medication, then you might instruct them to do that. But typically it would be before.
Thank you.
I mean, I'll add one other thing, which is that blood pressure varies a lot more than the man on the street, so to speak, would think. You know, we talk about one number, 130/80, or that sort of thing. If you actually do that on yourself and measure your blood pressure, even using the prescribed technique in a very meticulous way, there's a range that is 5 to 10 points that happens, and that's kind of part of the underpinning of using this multiple reading approach, is to average out that noise and be left with a signal that you can rely on. So part of the training of somebody in home blood pressure monitoring is, you know, expect variations. It's not going to be the same number each time, and that's to be expected. It's not a problem. It's not a cause for alarm. It's an expectation.
Yeah, thanks for that great point, that you take one reading and it's really high, don't freak out and run around, which is what I think I did the first time I did mine.
Yeah, right.
We have another question. I think I need to answer it. It's actually about the most recent community checkup that the Washington Health Alliance provides, and that we do not provide information comparing Washington State performance on blood pressure control versus the HEDIS 90th percentile. And I will definitely dig into that, but I believe the short answer is that at this time at the Washington Health Alliance, our data does not include information about control. We get nothing that comes out of the electronic health record. I know that there are CPT2 codes now that have come out within the last couple of years that can be dropped so that you can assess, you know, blood pressure controls. Like that's something that we can definitely do. So I will check that with our data team and make sure that whether or not we're able to capture those yet. But that's one disadvantage of working just with claims, is you have what's in the claim. So we'd love to get a better hold on that, and I'll check into it, and we will send that information back out to everyone. I think I have a couple more, if you have a couple more minutes. Dr. Dugdale, can you?
I see it.
Yes.
I read it, Sharon. I can speak to that. Thanks for the question. So my short answer to this question is that if there's a difference between office and home, I rely on the home. However, there are people for reasons that aren't totally clear, for which an elevated, sorry, actually there's a couple different scenarios. The most common thing people talk about is what's called white coat hypertension, where the office reading is high. It's not really a correct reflection of the patient, and home blood pressure monitoring is the typical way to sort that one out. So if the home blood pressure monitor is below 140/90, but there's an office reading that's above 140/90, unless it were really high or there was some other red flag about it, I would put my eggs in the home blood pressure basket, and that's what I would do. This business about how much variation occurs, that is a real problem with handling single readings, regardless of where they occur. And unfortunately, the more readings you try to get, the greater the burden becomes. And so some of those are kind of real world trade-offs that have to be made. But ultimately, the whole blood pressure is considered the more reliable reflection of what's real.
And Sarah Eve, folks are wondering if we can provide a link to those Department of Health tools that you mentioned. Oh, you're muted. Sorry. So easy to do.
I will make sure to include that. We have an order form, and that order form isn't currently available online, but it can be, you can contact anyone in our program to receive it. But let me send you the link, to put the link in for that, for where to find the publications, and then also my email and my colleagues' email to reach out to us. So for the order form,
we'll supply those resources to everyone. I think that was all the questions that we had. I just want to make a quick comment before I thank you both, but that DC said that 80% of hypertension is not in the Medicare population, because you said 20% of Medicare beneficiaries, basically, or whatever. Medicare beneficiaries constitute 20% of the people that have hypertension. So let's get rid of the idea that it's just for old people, right? And that the importance is definitely there for the Medicaid population, the commercial population. That's where 80% of these folks are. And so thinking about it with that hat on, that was a new fact for me completely. So appreciate knowing that as well. So thank you, Dr. Dugdale. Thank you, Sarah Eve. Thanks to Washington State Department of Health for all the support and encouragement. And thank you all for attending today. We will send out copies of the slides, and we'll make a recording available also. And the resources that you have requested will go out to you all. Thank you so much.
Great. Thank you, everybody. Have a good day.
Bye-bye.
thank you.